Our next speaker is Dr. Bulger, who truly needs no introduction, but she's the professor of surgery at the University of Washington, Seattle, and chief of the Division of Trauma, Burn, and Critical Care, is currently the president of the AASC, and previously led the Coalition for National Trauma Research. She is presenting today on limitations in prospective trials and what we can do there. So thank you, Dr. Bulger.
Thank you, and good morning. What a terrific session. I mean, this is really setting the stage, I think. I already have a list of deliverables I'm starting to take from the talks already that we've heard. So I'm going to highlight for you some of the challenges we have, some of the limitations we have, and I hope things that we can address as we move forward in this conference. So my objectives are to talk a little bit about challenges in data collection. We heard about some of the challenges with our existing data sets. How can we make those better is an important question and probably a deliverable from this conference. I'll talk about challenges in patient enrollment and think strategies around how do we make sure that we have diverse patient populations enrolled in our studies. What are the challenges in patient follow-up? And then I want to talk a little bit about something that I know Dr. Berry is passionate about, and that's the concept of intersectionality, which I think we have to factor into our research. So this is from Dr. Heider's paper that Dr. Berry really went through in great detail. I think it just highlights again that there are disparities in the entire continuum of trauma care. And so as we think about moving forward, how are we going to study this in every phase of care, and how are we going to get the adequate data to do so is going to be really important. So what are the challenges in prospective data collection? And this impacts our registries because our registries collect data retrospectively in general, but they get it from the medical record, which is collected from the patient, right? So this is a challenge in how we collect this demographic data in a way that makes it accurate and reflects all of the different perspectives of patients and how they perceive their race and ethnicity. You talked a little bit earlier about some of the buckets that people are put into, that maybe it's not the bucket they feel like they should be in. Or what about people who have a mixed race or mixed ethnicity? How do we deal with that? How do we collect data on the social determinants of health? Dr. Berry made a case that we need to collect this data, right? But how do we collect it in a way that it's accurate, that the patients are comfortable sharing that data with us? Because just sharing that data might lead to bias, right? If I say, oh, well, you know, I live in this neighborhood, or I don't have insurance. I mean, there are things that will lead to bias in the moment that we have to be conscious of. So a really nice paper that was published in Injury in 2023, just recently, from our own Injury Prevention Research Center, was a qualitative study where they interviewed 136 racially and ethnically diverse trauma patients to try to develop a culturally resonant process to collect health equity data. They pilot tested a bunch of different questions with 109 patients and then validated it subsequently. And one of the important things that they found in talking to real patients is they wanted to know why we're collecting the data. Simple thing, but we often don't say that. We just say, go through a checklist. Tell me about your registration. We'll go through a checklist. Tell me this, tell me this, tell me this, tell me this. Turned out that we needed a script, and the script was evolved over time through this qualitative process to explain why we collect this data. So this is the script that was published in the paper. It says we ask every patient these questions. We know some people are treated badly because of discrimination. We're asking these questions so we can learn more about the people we serve. This can help us better serve our patients in the future, and we have policies to protect your information. So these are simple things that we don't often think about. These just, data is just collected and it ends up in our registry. But how we collect this data, how we ask the questions are going to be very important. Okay, let's talk a little bit about challenges in patient enrollment. So obviously there's lots of that's been written about distrust of the medical system and distrust of medical research, and there's good reason for that, right? We all know the history of marginalized populations being very badly treated in research. In 2020, there was a survey that was done of over 1,200 patients from underrepresented groups that included a broad array of folks, including Black, Latino, LGBTQ, patients with low socioeconomic status, and they reported that 1/3 of those that were interviewed had a lack of trust that prevented them from participating in clinical trials. So that is something we have to overcome. We have to find a way to build trust so that we have representative populations in our trials. One of the challenges is that we have a lack of culturally competent approaches to patients and their families. How do we train our research staff? What sort of training do they require in order to approach patients in a culturally competent way? And do we have the right diversity in our research staff? Do we have folks in our research staff who are native speakers of the language of the patient? It can be critically important. There's certainly limitations in translation of consents into multiple languages and the availability of interpreters. I've done a lot of clinical trials where they make you translate it into one language, the most common language being Spanish, but not others. I have a huge Vietnamese population, a huge African, Ethiopian, Somali population. We're not translating into any other languages. And then there are challenges in excluding criteria for clinical trials. So very frequently, we'll exclude patients because they can't follow up with us. Right? We want good data, we want high quality data, but if you don't have stable housing, you don't have transportation, you're not English speaking, those are frequently exclusion criteria in our trials. Voice is really funny. Not me. I'm change this thing. Thank you. Is that better? Ooh, yeah. All right. So there is work being done on this, and this is a nice paper. This is from the Clinical Trials Transformation Initiative. It's a framework that's been created by funders, and this is a lot of this is driven by pharmaceutical companies and large people who run large drug trials. But really looking at what are the motivations behind different stakeholder groups and how can we engage them in enhancing diversity and inclusion in clinical trials. So this is a good start. There's also work that's been done to help researchers set goals for their enrollment. And this is, again, another nice framework which requires that you look at both the U.S. Census data, as was shared with you earlier, and how that's changing. But you also look at real-world data for the disease you're studying. So trauma, for example, often involves patients who are at increased risk because of their social determinants of health. And so if we don't take into account the real-world data of the patients that are injured, then we're not going to set appropriate enrollment targets to ensure that we have a diverse patient population. So this is a nice framework that's been published as to how to do that. I think the other thing that is really nice is this paper, and there's a reference at the bottom that you can't see, but we'll send the slides out, which provides a really nice overview of some of the barriers to clinical trial participation and then the solutions to that. So it talks about issues around access that I talked about, just getting the ability of the patient to get to and participate in trials, awareness of both the patient that there's an opportunity to be in a trial and how we approach patients, racism, which is obviously a factor in all of this, what are the biases that lead to changes in enrollment, and then workforce diversity. Again, do we have the right members on the team in order to enroll a diverse patient population? And this is a map from the Center website. Center, as you heard earlier, does a lot of clinical trials, and this just shows all the different sites across the U.S. that have participated in our trials. But we don't think a lot about diversity sometimes when we select study sites, right? I think when you're trying to set up a trial, you'll think about, okay, well, who do I know? Who's my friend, right, that I can reach out to be a study site? And who does good research? Who does a lot of research in this area? But we don't necessarily think about, do I have the right diversity, access to the right diverse patient populations in my trials? I think that's something we have to consider as well. All right, how can we then work towards diverse enrollment in trauma trials in particular? I think there are things that are low-hanging fruit for us, right? We talk about trauma-informed care in the hospital. We need trauma-informed care training for our research staff. Something we may not think about, but again, we want culturally competent people to be able to approach patients for consent, for enrollment and inclusion in trials. We should do role-playing for new staff who are learning the consent process. That's probably good practice in general, but often not done. We should hire diverse research staff, including those who speak the languages that are most commonly spoken by our patients. Native speakers. I'm doing a trial right now with one of the psychiatrists, and he said, I'm going to hire a research assistant who's fluent in Spanish. It's critical to my trial. We need to translate study forms into the most common languages encountered, more than one language, and then consider having a diverse panel to review your documents and give you feedback. I think a lot of what we're going to talk about is patient-centered research. How do we involve patients in our research up front? And this is one area where we can do that. Now, a lot of the trials that I've done in the past have been under the exception from informed consent regulations, which are unique to emergency trials and certainly to our space in trauma. And most of you are familiar with this. This is a really nice paper that was a systematic review of community consultation surveys. They looked at data from 27 different trials. There were 42,000 survey respondents. This is how you engage the community before you do the research. And it was interesting that public approval varied based on how the questions were asked. And African Americans made up 29% of those who were enrolled in these trials, but only 16% of those who were surveyed in the beginning. Men were also underrepresented among the survey respondents. It seems like more women are willing to engage in the surveys. And some survey data was weighted to account for these differences, but groups that had higher portions of African Americans and men had lower rates of approval of EFIC. So I think as we think about how we do these trials and how we engage the community in these trials, we need to make sure that we have a strategy to really hear all voices and make sure everyone's represented. So strategies for EFIC trials: assessing the populations, again, at greatest risk for injury, defining your geographic catchment area, and for both community consultation and community notification, which are the two critical components of EFIC trials, I think we need to develop strategies that solicit feedback specifically from at-risk groups, and we may need to oversample certain marginalized groups because they're going to be more likely to be included in our trials. For community notification, we need broad outreach in multiple languages and multiple venues. One of the things we did in Seattle for one of these trials, because our IRB said, how are you reaching the homeless? They're not looking at your website. They may not watch the evening news when your trial is presented. So we had to put signs on the side of buses that described our trial so that people could see them in the community. So things like that are really things that we don't think about, but allow us to reach that population. The other challenge we have is in patient follow-up. And we talked a lot, I think, about the need for long-term outcome data. That's sort of a universal challenge. But how do we get it? How do we get it? What are the challenges? We have lack of internet access. So if we're using internet systems to try to get our follow-up, we may not get it. If we need to bring the patient back and they don't have adequate transportation resources, that's a barrier. Again, unstable housing, may be hard to find the patient. If they have mental health and substance abuse issues that haven't been dealt with, that can impact their ability to follow up. And of course, language barriers. So what are our strategies here? Again, it's the relationship that we develop, we think, with the patient while they're in the hospital and with the family while they're in the hospital is critical. And that's where that cultural competent research assistant becomes so important. We need multiple points of contact. We need to understand the patient's contact preferences. We need to monitor the EHR for follow-up visits. Maybe they're not coming back to see us, but they're coming back to see the orthopedic surgeon, and I can sneak into that clinic and get some follow-up. We need to offer a regular contact prior to the defined follow-up window. So maybe the window is 6 months. Typically for outcome studies, it's 6 months or a year, right? Well, let's talk to the patient at 2 weeks, at 1 month. Just check in, how you doing? So we have a regular contact strategy so that at 6 months they're going to answer our phone call. To develop relationships with the local homeless shelters and with the local jails and prisons. And we did this in several of our trials where we would find that a patient was subsequently incarcerated and no longer could we talk to them, but actually have a relationship with the prison, and you can reach the patient and have a discussion. Finally, this concept of intersectionality is way more than I can go into in the time in this talk, but I think it's something we need to think about over the next few days. Intersectionality recognizes that individuals may belong to multiple social identities that have overlapping and complex systems of discrimination. So we tend to put people into single categories with the social construct that we just heard about. But we have to recognize that people are impacted by these multiple factors. And all of these factors can impact the risk of injury, the severity of the injury, their medical care, and their outcomes. So we shouldn't, as researchers, try to assess them in isolation. We need ways to adjust and adapt our research to address where people are really at and what's really impacting them. I will give you one example of that. This is a paper that was published from my institution, and it is called Intersectionality of Systemic Disadvantage and Mortality on Care Following TBI. These researchers did a latent class analysis, which is an interesting way of identifying groups that have intersections of disadvantage. They identified 4 TBI groups: white English-speaking adults, which is the least discriminated group, people of color who were adults, people of color who were also non-English speaking and older adults, and white English-speaking older adults. And not surprisingly, there were some significant differences in mortality between these groups in unadjusted analysis, especially between older adults and younger adults, as you would expect. But there were also differences in the severity of TBI on presentation and in the mechanism of injury. And so when they first sent me this paper, I said, do you guys look at, do you risk adjust? Did you look at the severity? Did you look at the mechanism of injury? And they had not. They also not adjusted for comorbidities in these patients, which, as you can imagine, different populations have greater risk of other medical comorbidities as well. So as researchers, I think we just have to recognize this intersectionality and understand that there are many factors that impact the risk of our patients, not only of their outcome, but also their upfront risk based on their risk of being injured in the first place and their severity of that injury. So lots of work to be done in this space, but I think it's important for us to think about that when we design our trials. So in summary, I think there's a lot of opportunity here, and I'm really excited about this conference because I think this is a chance for us to think about it, to talk through it, to develop strategies, to put out some guidance for researchers. On the data collection side, we need strategies to standardize the routine collection of patient demographics and social determinants of health variables. Somebody else said it earlier, right, that I think it was Dr. Zog said we need, as a community, to say, here's what we think is important, here's what we're going to collect, and we're going to collect it in a way that's culturally competent. So that's a deliverable, I think, from this conference. How are we going to do that? We need to think about vetted messaging, too, in collecting this data so that patients are comfortable sharing this data with us. Patient enrollment, we need to develop culturally competent strategies that support diverse patient enrollment, set enrollment targets, consider patient population in our study site selection, and for EFIC trials, make sure that we are adequately sampling at-risk groups and weight our survey data. For patient follow-up, we need to develop strategies that allow patients with limited support to be enrolled in our trials, and we need to consider intersectionality in study design, including data collection and our analysis plan. Ultimately, our goal is to engage a diverse group of people in our studies. We should engage them up front in helping us design our studies to make them culturally appropriate. So thank you so much for the opportunity to spend some time with you today, and looking forward to the discussion.